In this part 2 of Preparing for Fieldwork series, we will be going over the personnel of the hospital for acute care. This information will apply to probably other settings as well, to a degree such as acute rehab, but the focus will be on acute care. Although there may be changes in how the team at your fieldwork setting will be from a collaborative standpoint, like the model, I will be explaining this from the traditional medical model, as it is still quite common in terms of where fieldwork students may work and what they will encounter. In a general sense, this means that at the top of the hierarchy are the physicians and the specialists, and below them are the rest of the staff, such as the nurses, therapists, and technicians. In order to avoid making this video like 10 hours long, I won't go into too much detail, and instead I'll explain the team in general. I will also explain the role of these healthcare providers and their importance relative to occupational therapists when it comes up. If you are new to this channel, my name is Jeff, a board certified and licensed occupational therapist practicing in America. A common misconception about occupational therapists is that they help people to find jobs, but instead they help people to do the things that they want to do that are meaningful to them. My goal is to increase awareness about the profession of occupational therapy to help people live healthier and happier lives. If this resonates with you, consider subscribing to this channel and joining to be a member. Check out the video description for more free helpful resources, such as my website, and for other ways that you can support this channel, like grabbing my merch or my handmade badge reels. Thank you all so much for your support. I'm the OT Dude, and let's get functional. In acute care and basically in the hospital, a patient who is admitted is often assigned a hospital doctor, also known as a hospitalist. The hospitalist is kind of like your family practice doctor, or for minors, a pediatrician. They are kind of like the gatekeeper, and just like in family practice, as your primary care physician, you know how like they refer out to specialists based on what you need, like a urologist or a neurologist? Well, based on a patient's diagnosis and what's going on in their condition, they may have additional specialists that follow them in addition to the hospital list. For example, if a patient is admitted to the hospital for a stroke, they would likely have a hospitalist and a neurologist. And if for a cardiac issue, then also a cardiologist. If cancer, then an oncologist, and so on. A patient may even have multiple specialists based on what's going on, their comorbidities, and the complexities of their condition and their case. While the hospitalist will follow the patient throughout their hospital stay, specialists may drop off and discharge their services if they are no longer needed. For example, if there is a UTI that resolves and the urinary function returns to normal, then a urologist who may be seeing a patient may discharge, kind of like therapists, and the patient may only be left with the hospitalist if the UTI is not the primary diagnosis, especially, or if the patient else still has going on that's keeping them in the hospital. The hospitalist is typically the same assigned one for the patient. However, in real life, the hospitalist may change if the hospitalist does not work like back-to-back days and they take a break or something like that. So this can add to the communication barriers and lead to potentially decreased quality of care if things are not passed on to the oncoming hospitalist. Overall, the role of the hospitalist is unique in terms of OT, as they're like the point person for everybody else because they're like at the top of the medical model, right? Hospitalists are often the main ones who order the labs, the tests, and the diagnosis, like make the diagnosis. They may decide on the discharge date, like the final say, and overall plan. That's not to say that other staff doesn't have a say or that family doesn't have a say, but the hospitalist is often the one who places the discharge orders. Sometimes the hospitalist may page or ask the OT even for input on the discharge plan. Pretty cool, right? So knowing who the hospitalist is also important because sometimes you need to document their name in the chart, such as for evaluations and even for progress notes. Depending on the culture of the workplace and the preferences of the physicians and specialists, sometimes the nurses are the middlemen and the ones who help to relay the messages between the hospitalist and you, the therapist. And each physician may be different in terms of what they prefer. Some may prefer to be paged, some texted, some left a voicemail, and overall, to a lesser degree, some directly being called. Don't worry about learning who the hospitalists are and all the things like that. But as a student, there may be many of them, but try to write down who it is, at least so that you can document who it is for the evaluation and to reference them for documentation, basically. And speaking of this, there are surgeons, such as in orthopedics, and you sometimes need to know who they are because you need to verify things, right? Like precautions, such as weight-bearing precautions. And for OT, PT2, many surgeons may have their specific protocols for what's allowed, such as the movements or the exercises you can do or the weights that are allowed, things like that. An example is in the shoulder and what movements may be allowed for function and exercise. Or if there was a craniotomy, for example, such as due to brain cancer or a traumatic brain injury, it'll be a good idea to know what the protocol is based on the surgeon because you'll need to know when patients may be allowed, for example, to be showered or they may get their head wet or not. Just something to be aware of. I mentioned nurses earlier, right? So you'll actually communicate with nurses quite often. You typically check in with the nurse before seeing your patient and to brief with them after the session, especially if there are any acute changes or anything worth noting. Of course, if a patient becomes symptomatic, like I said, then it is imperative that you notify the nurse right away. And if you can't get a hold of the nurse who is responsible for your patient, then notify the lead nurse. Pro tip is to write down the nurse and the lead nurse's extension numbers down, like on a piece of paper, so that you can page them in case of an emergency, or if you just need to get a hold of them in general and you don't want to like walk all the way to the nursing station, like all the way around the end of the hall, around the corner, and just takes up time. You should also be familiar with how to call a code, such as a code blue. If you're a student, then your clinical instructor will probably take care of that for you, but just be aware of that. One thing that you should know is that nurses may work on their primary unit, that is their home base, but sometimes they may float to other units as well, so they may be less familiar with things compared to nurses that work primarily in the unit that they often do. Examples of collaborative goals that the nurses and the OT can work on, which is really cool, is, but not limited to, safety, precautions and following them, communication, mobility, transfers, self-feeding, bowel and bladder function, grooming and hygiene, running out of fingers here, bathing, which is typically done at bedside in acute care, such as sponge bath, pain management, symptom management, skin integrity, and discharge planning. It's important to keep the nurse in the loop of the patient's progress too in therapy and give them a quick, you don't have to like write a whole like progress note and like, or tell them the whole progress note, just give them the highlights. So just be efficient. Nurses also often have CNAs or care partners, and they are the ones that you may work with more directly, such as to help manage ADLs. For example, I had an awesome CNA who I worked with for activities such as toileting and hygiene. But don't be confused about the CNA or the nurse with the role of a nurse practitioner, NP. NPs have a similar role as PA, physician's assistants. For example, where I work, there is a trauma nurse practitioner, or NP, who I often communicate with regarding the patient's discharge plan, and this is an entirely different person in addition to the regular nurse for the patient. Depending on where you work, you may have NPs PAs, or a combination of both. These professionals can often place orders and are responsible for the care of the patient alongside the physician, including the discharge plan. So far, I've mentioned discharge plan many times, so let's talk about related personnel for that. Case managers and sometimes even social workers. As an OT, you should check in with these professionals regarding the patient's discharge plan, including any questions and concerns that you may have. It's their job. They often can provide a wealth of information as they work with insurance, the family, and other personnel to kind of glue everything together besides the hospitalist. I like to check in with them and recommend DME and adaptive equipment, family training, discharge setting recommendations, and from time to time, what's really expected from the OT's perspective so that they can get a broad overall holistic idea of the patient and their function. And depending on if you have an inpatient acute rehab ARU or not, it's important to keep this setting in mind because you may refer patients to this setting because it may be, say, built into the hospital, like physically. And so case managers will love to know these recommendations because it can help them to get a head start and the ball rolling on how to make that happen, such as by calling insurance or talking to the doctor who is working in the acute rehab unit, also known as the physiatrist. In terms of therapists, the three that come to mind are speech therapy, physical therapy, and respiratory therapy, besides occupational therapy. Sometimes you may co-treat with these therapists, especially if the patient is a complex case and they would benefit from two different disciplines at the same time being present, such as for weakness, having PT there, or like dysphagia, having SLP there, speech language pathology. Other examples of collaborating with speech language pathology, either co-treating or just in general, is for cognition, communication, language, and just general overall safety concerns. Or if they're having trouble with remembering things, just any cognitive deficit and how they may benefit from function with integrating speech language pathology strategies. Examples of PT are pretty obvious, but interventions such as for mobility, transfers, orthotics, like AFOs, and physical agent modalities, PAMs. And with COVID-19, it really highlighted the role of respiratory therapy and our awesome respiratory therapists. While it's rare to directly like co-treat with a respiratory therapist compared to say speech and PT, I don't know if we actually even do that, but they are a useful resource, especially if you notice an exacerbation in respiratory like breathing and they may have dyspnea or have like a productive cough or something or asthma. So another great resource, especially if you see them around. Have you worked with them? Do you think their condition is improved? How do you think their breathing is? What kind of activities do you think they can tolerate? A lot of good questions you can ask them. Some places may have COTAs working alongside OTs, but where I work, they are less common. And this may depend on location as well, like states. If you are fortunate enough to have Rehab Aides, then they are also a great resource to help with, say, keeping the environment clean for like the gym, maintaining equipment, making sure things are working properly, tagging things that are broken, and ordering more equipment and supplies and things like that. Because, you know, it's hard to keep on top of these things and an inventory of things when so many pieces are moving at the same time. And it's just a job in itself. So yeah, mental health is another important part of someone's stay in the hospital, right? So you may work with psychologists, psychiatrists, and other mental health professionals such as counselors. They are a great resource to refer to for mental health interventions, including, say, for psychotherapy. Typically, when I work with new patients, I keep a mental list of who may be good candidates to refer to the psychiatrist at my hospital so that they can come and evaluate them. Not only see them, but when they see me, they'd be like, oh, I saw patient A and yeah, I discharged them. I saw patient B. I think they can benefit from a lot of psych. I'm going to try this with them like CBT. You'd be like, okay, great. Then I can integrate that into my OT session. So pretty cool. You may even co-treat with mental health professionals, for example. So psychiatrists may be also a helpful resource for medications, right? Prescribing or dialing in medications to help them manage their anxiety, depression, psychosis, and so on. Referring out to another mental health professional is beneficial because there's so much for an OT to do in acute care, and they can provide additional mental health interventions so that you can integrate that into your practice, but also focus on more physical things as well, such as ADLs. Speaking of ADLs and eating, there's the dietitian. They can be a great resource to refer out to if there are concerns with intake and diet. They are often referred by other staff already, such as a physician or nurses, but sometimes this may be overlooked. The dietitian or the nutritionist work closely with other staff too as well. Nursing, speech, language pathology, and the physician. In acute care, one challenge is that things often change and they're so dynamic, right? Including when orders are placed, then things typically happen like right away. So staff may want to share or use some of that time or like fight for the time to work with the patient. For example, technicians may want to perform their testings, phlebotomists may want to do their lab draws for lab orders, coordinators and administrative people may want to come and have a chat with them or have some things signed or verify things with the patient. Spiritual health may want to drop in and like have a prayer with the patient, or the doctor may come and do their rounds, or the nurse may be already working with the patient and so on. So the challenge is deciding when to prioritize your time for therapy and not allow yourself to be interrupted or to step back out and come back later. So this is like a skill that you'll kind of develop in itself, but you can ask your clinical instructor what to do in these cases. If things are more urgent, such as like x-rays, then yeah, these are more important compared to like other things. And this is different than in acute care because the time that patients spend in therapy are very important because they need to meet like the 3-hour therapy minimum rule for insurance and Medicare and things like that. So that's different than in acute care where the timing isn't as much important in the time that they spend doing therapies. And while not medical professional, there may also be visitors and friends and family, right? So depending on the situation, they may be productive or distracting for therapy. I'll make a separate video on family in itself as it's a very important and I can go into a lot of content for family. But in general, I like to keep visitors to a minimum when working with patients to minimize overall generally the distractions. It's also a good idea to designate a point person for communicating and for discharge planning so you don't have to repeat yourself like 20 times and it could be staff splitting and things like that. Also, if a patient's name is kept private or confidential, then this is something to keep in mind, especially if you see in like the whiteboard by the nursing station, if their name isn't displayed like their last name, then they're probably confidential. So you'll want to be careful of things like HIPAA and not sharing like, for example, where the patient's room is if a visitor comes and is like, oh, where's so-and-so? Because there may be safety concerns here. It's best to ask the nurse in this case if you're unsure, but reasons for why patients do remain confidential includes suicide attempts, domestic abuse, gang violence, attempted murder, those kinds of things. My last and most favorite of the ancillary staff is EVS, or environmental services, who are responsible for things like janitorial and keeping the hospital looking welcome, neat, and clean and sanitized. Why are they my favorite though? When EVS is not there or they're understaffed, you'll notice things like toilet paper not being refilled, trash not being emptied, floors being a little bit sticky, things like that. According to a popular legend, during a tour of the NASA headquarters in 1961, John F. Kennedy encountered a janitor mopping the floors. And JFK asked, "Why are you working so late?" And the janitor responded, "I'm helping put a man on the moon." So it takes a village to keep the hospital running smoothly. While there are many staff and professionals that we typically think about, and many that I didn't mention also, I wanted to take a moment to say thank you for everybody who works in the hospital or are part of the system, such as like IT and, like people who paint the walls. Anyways, thanks for watching, and I hope this helped. I'll be making more content. I don't know what to make the next one on. There's so much to talk about for acute care. So be sure to subscribe to this channel and give this video a thumbs up so that you will know when the next video drops and you can watch it right away. I'm the OT Dude, and have a nice day.